Dr. Keith. I now invite Dr. Kaweh MANSOURI to give his talk on plastic surgery versus MIGS, how to decide.
Good afternoon, and I'd like to thank Professor Tanuj Dada, the All Indian Society, and APO for the invitation to speak here. I will be discussing mixed versus classic glaucoma surgery and trying to make a bit of sense of how best to decide. These are my disclosures, some of which are relevant to this topic. And while trabeculectomy is still often considered our gold standard, but it is a gold standard that is now about 80 years old, and it assumes a special position, I would say, in ophthalmology and in medicine. It's probably one of the least predictable surgeries in ophthalmology and maybe beyond. And this is because despite perfectly executed surgery, oftentimes you can have a host of early or late postoperative complications, some of which can be quite devastating. And your results are still highly dependent on how the eye reacts to the surgery and how it scars, essentially. In the good old days that were not that good, hopefully not that old because I was still a resident, our thinking in how to proceed with surgery in glaucoma eyes was quite simple. We would start usually with trabeculectomy, or in some regions such as mine in Switzerland, we would do non-penetrating glaucoma surgery, deep sclerectomy. When these failed, we would proceed to the next stage, which were glaucoma drainage devices. And when these failed, finally we decided to cyclodestruct the ciliary body. Today, we have more modern options available in the category of MIGS that provide us often through an ab-internal approach a safer, less traumatic IOP reduction and provide a faster visual recovery and bring the patient faster back to his normal life or work, and can have also socioeconomic positive impacts. Well, a few years ago, when MIGS were starting, when the evidence on MIGS was still sparse, there were many questions and discussions about whether they even had any effect in any role to play in glaucoma surgery. Some colleagues refer to them as MEGs, for minimally effective glaucoma surgery. In 2019, the World Glaucoma Association convened about 100 eminent glaucoma surgeons from all regions of the globe in Melbourne during the World Glaucoma Association's meeting to discuss the topic of updates to glaucoma surgery, and came up with a consensus on glaucoma surgery. And the consensus clearly back then, that's about 5-6 years ago, was that there is growing evidence that minimally invasive glaucoma surgery has a role to play in glaucoma surgery. It is not completely ineffective, but that the evidence available back then was still short-term, usually between 1 to 2 years, and excluded many ethnicities, except Caucasians, from the study. So there were many limitations back then, and this has really changed since then, maybe also stimulated by this consensus statement, clearly putting down the limitations of available evidence back then, that many colleagues, many centers, and also manufacturers decided to address these concerns of limited ethnicities, data availability, limited duration of data availability, and also regulatory agencies in many regions in the world, in Europe, in the US, and beyond now, actually demand more than 1 or even more than 3 years of follow-up data to decide if a technique, which often is costly, is also effective and should therefore be reimbursed by approved by regulatory agencies and reimbursed by payers. For all those of you who don't know the consensus, I highly recommend reading it. It is now 5 years old, but it's still relevant to us. The time I have is very limited, so I cannot discuss all the mixed groups, techniques that exist, and this graphic is not even complete because there are so many of them, and some of them come, others go. I'm going to discuss those in red, which are those that I use routinely in my clinical practice, and for whom we have a good body of evidence. The Zengel stent has been around for about 11 years now. We had a 45 micron size and now the 63 micron size, so a larger lumen size, potentially draining more aqueous and lowering IUP more. It was approved in Europe, in the US, and in many parts of the world. We have 5-year data published for this technique. This is from our group in Lausanne, and this was a prospective study that we initiated in 2015, including also our very first cases where we will still not be on the learning curve, not just in terms of how to do the surgery, but also how to manage it. Also, the manufacturer or the distributor back then really didn't know much about how to best manage post-operative complications, when to do needling, how to do needling. So we were learning ourselves, like other colleagues who were starting on the job. And these data are reflected these limitations are reflected in the data. What you see, nevertheless, despite these limitations, is that almost 50% of data were available after 5 years, so about a response follow-up rate of 50%, and that IUP was significantly reduced from about 21 millimeter mercuries at baseline to the low teens, around 13.5 millimeters, and we have published the data. Needling rates were around 30 to 50%, depending on which patient selection you included here, so high needling rates. Preserve flow, as Professor Barton spoke, came afterwards, goes through a different approach, ab externo versus ab interno for the Zen. The material is a different one, and also the size of the lumen and the size of the implant is a bigger or longer one here. The availability of data in terms of follow-up more limited because the device is more recent, but we have 2-year published data which attest to its efficacy and to its safety, very comparable to the Zen. If you compare the two to each other, you have more data available for the Zen, of course, because of the longevity on the market. There's one single study, to my knowledge, that compared the two to each other in a retrospective, limited duration fashion, and it found that in terms of IUP reduction, medication reduction, there was no statistically significant difference between the two, and in terms of safety, they were quite similar. There were some differences in terms of post-operative management, for example, the Zen requiring more needlings versus the Preserve Flow required more revisions. But globally speaking, in terms of safety or efficacy, there were no significant differences between the two. But this was not a head-to-head prospective randomized controlled trial, which is still what I believe we would need to address the question of which one, if any, is best for glaucoma patients and what would be the risk factors or the predictive factors for success. Going to a different approach, the so-called angle mix, I'm going to discuss 3 of them here. The iStent, of course, everybody's very familiar with it. It was probably one of the very first mix approved. Therefore, we have a lot of data, some high-quality data available for it, and the iStent inject, was the latest iteration. 5-year data were published about 2 years ago by Ike Ahmed and colleagues in a study that was randomized, controlled, and compared phaco alone to phaco augmented with iStent. And safety data as well were published at 5 years, which is precious because the question of safety and of endothelial cell safety has become more relevant since the withdrawal of the CyPass due to endothelial cell safety concerns. The study here showed that in terms of endothelial cell loss, the iStent is extremely safe, and they could not find, in fact, any added loss of endothelial cells compared to performing phaco surgery alone. Hydrus is another stent to enhance aqueous outflow through trabecular meshwork into Schlemm's canal. Is larger, is a different material. Technique is slightly different than the iStent. And also here we have high quality 5-year data from the Horizon study available. This was an even larger study of 556 eyes, and it found that in terms of IOP lowering, there was no significant difference between phaco alone or augmented with Hydrus. However, there was a significant benefit in terms of medication reductions when phaco was augmented by putting in the Hydrus. And there were, over 5 years, fewer secondary glaucoma surgeries required in patients who had a Hydrus added on to their surgery. These are the data of the 5 years. You see that the IUP results look quite similar, and then you have some more detailed breakdown in the table on the right-hand side. What was interesting was the question again of how endothelial cells fare. There were some concerns that because of the larger size of the implant than compared, for example, to the iStent, the fact that a larger portion may be present in the anterior chamber compared again to the iStent, there would be a significant loss of endothelial cells, which, well, depends on how you analyze the data and how you interpret the data that were presented in this paper may be the case. So you can see on those bar graphs that the difference between phaco alone and augmented with hydrous after 5 years is present. When you look at the numbers themselves, they look, it seems to be a bigger loss. However, that was not statistically significant. However, I would say based on this data, we want to be sure that we place the device really as deep within the Schlemm's canal and not have too large a chunk of it be in the anterior chamber. It is a metallic device, and if in contact with endothelial cells, may cause significant damage. One of the interesting studies in this field is an RCT that compares iStent to the hydrous. 1 year results were published a few years ago. That's the so-called COMPARE study. And it found in a clear manner that in terms of IUP and medication reduction, hydrous was more effective than iStent. Goniotomy with the KDB is another approach to enhance aqueous outflow through cerebral meshwork by excising a strip of about 100 degrees. It is an elegant method. It requires a simple device which is not very costly, and there is no material left in the eye. And Dorai Raj and colleagues presented recently 6-year results of this technique. It was a retrospective eye, a study limited to 60 eyes, and they looked at KDB alone versus KDB combined with phacosurgery. And they found a success in 46% of eyes. Only 4 eyes out of 90 require secondary surgery intervention. So in terms of reducing the risk of glaucoma surgeries, it was effective. And when you look at the bar charts presented here, you see that there was a significant and actually important reduction in terms of IUP and medications. We know there are different ways to do a goniotomy that may be preferred by some or that may be less costly, and you're familiar with the bank technique or the Tanito microhook. One limitation of all these techniques, going through the ankle and enhancing aqueous outflow through cerebral meshwork, is that there are structures, of course, beyond the Schlemm's canal, which have an influence, which may have a very strong influence even on whether these surgeries work and IUP comes down or not. And here we are talking about the location, the density, and the state of collector channels. Unfortunately, we cannot visualize them easily, and definitely not reliably, non-invasively during our surgery. Alex Wang and colleagues at UCSD have spent significant time studying this question by, for example, inventing a technique called aqueous angiography, where you can intraoperatively visualize those, but these techniques still are not available to every surgeon. You need special instruments and special techniques to do this. However, they have shown that once you can visualize where collector channels are located and decide whether they are in so-called low or high flows, placing your stents according to this location may have a significant effect on your surgery. So these are techniques which we hope will become better, easier, and less invasive in the future, and guide us in placing our stents or in performing ablations in a more targeted manner and hopefully improve surgery. We are not there yet. Another way maybe to fully overcome the question of collector channels is to go in different space, which is a supraciliary space. The concept of it is not novel. In fact, it dates from over 100 years ago when a German ophthalmologist, Leopold Heine, published that when you create a cyclodialysis cleft, you lower IUP significantly. The concept back then did not catch on. It was actually very much attacked, and also due to the fact that there were no operative microscopes and definitely not no safe devices, stents or implants to be placed there to keep that space, to open that space in a controlled manner and to keep it open in a controlled manner. The concept clearly was that there is a negative pressure gradient in that space that you create compared to anterior chamber. It sucks in aqueous humor in a more important fashion than any other MIGS device could potentially provide. The CyPass showed IUP efficacy, but it also showed bad safety results and was withdrawn. The MiniJect, as a successor, has decided to use a more soft material, a silicone material, and to place the stent more posterior. You see the device here, there's a green ring, and the green ring is supposed to be barely visible in the anterior chamber so that the implant itself is far away from corneal endothelium. It can be combined with cataract surgery or done in a standalone manner. It's very similar to the other angle MIGS. You create a corneal clear incision, 2.2 size. You go in with your delivery tool and you create a cleft and place it there. 3 pivotal trials were performed, STAR 1, 2, 3. We pulled data from all 3 trials to see the countries and populations where they were performed. Some of them were ethnicities that are usually considered high risk for scarring. And we published the 2-year data in AJO 2 years ago. In essence, IOP reduction was significant, almost 40% after 2 years, with a success rate of almost 90%, 85% of patients having IOPs at or below 18, and 38% of patients being completely medication-free. So these are numbers that are, I would say, better than most MIGS or all other MIGS that do not go into supraciliary space demonstrate, again, attesting to the IOP lowering effect of this space. It can be more safety concerning theoretically. We were wondering about rates of hypotony. We were a bit worried by rates of hypotony, I should say. However, we were reassured that hypotony did not seem to be a significant risk here. Sorry for being over time. We have 5-year data now, not published yet, where we find that this lowering is mostly maintained after 5 years in a limited amount of patients, 47 patients where data were available. And the device seems to remain safe also in terms of ECD loss. We did not find a large ECD loss close to what the CyPass created. Now going back to classic surgery, I'm talking here about trabeculectomy or in our case deep sclerectomy. It is a method that has been out for many years, which is an elegant technique, however it's more invasive. But we know it creates aqueous outflow through different pathways, subconjunctival, but probably also into the supraciliary space and due to the way this surgery is performed. You can combine it with IOP measuring sensors, not yet widely available, and these are benefits. TRAB was compared to Zen in a GPS study, and the results after 1 year showed that TRAB, of course, was more effective, but the difference statistically was actually not there. Zen was non-inferior to TRAB in this one study, which differs from other studies, but this was a controlled randomized study. So to finish, with the data we have available now, how should we proceed? This is my own simplified or much simplified algorithm. First, I would say any glaucoma surgeon should be able to perform several MIGS and standard classic filtering and tube surgery. This is part of what a surgeon in glaucoma should be able to provide, so that he can personalize the surgical technique as much as possible to his patients, of course, dependent on the context, economical context where you practice. In patients who have early to very moderate glaucoma, and where the purpose of surgery is essentially you're doing a phaco, you want to reduce one medication, in that case I would do angular surgery, hoping to reduce maybe the medications pre-existent. In the second step, patients who have more moderate glaucoma, your aim is a bit more ambitious. You want to lower IOP and lower medications. And in that case, I think subconjunctival MIGS are more effective. And finally, if you need to lower IOP to the low teens, which is the case in more advanced glaucoma stages, then I would still opt to choose our classic techniques, trabeculectomy, deep sclerectomy, GDDs, because we know they have, with a higher likelihood, the lower pressures that you need.